Okay, so we are following the program, and the next presentation will be done by Dr. Liuda Brogiene, and the topic is pain management in athletes. So we're curious about that topic, and I know that the doctor saved some athletes' careers and even participation in Olympics. So.
Hello, everyone. Hello, dear colleagues, and thank you, the scientific committee, to having me here. And well, I will speak on pain management in athletes, and my presentation will be mostly for professional athletes, or in other words, elite athletes. I have nothing to disclose. And if we're talking about the networks, so I am the presenter of the network. I'm anesthesiologist working in ICU of cardiology, and at the same time I'm doing pain management. So it's kind of the network that connects one word, pain. Here I have my poster numbered with 6, and why I want to share this information that came from my research in cardiac intensive care unit. It's about acute pain and prevalence of acute pain and chronic pain. And in very interesting conditions or setting, it's pain after procedure, PCA procedure, percutaneous coronary angiography. So interventional cardiologists will tell you that there is no problem about that. It's only symptom. If the patient has pain, so there is a complication. We can see the same thing in injuries. You can say that pain is only a symptom when the athlete has an injury. We found a little bit different things here. So we found the risk factors, and we found that patient, even without complications, have a pain at the wrist because the procedure was made during the radial artery. There is nothing painful about the procedure, but after the procedure, more than 50% of patients have acute pain, severe acute pain, and 3.7% of those patients have chronic pain conditions afterwards, after this procedure. And they have, some of them has no complications, and the pain cause can be different in acute pain settings, the same in athletes. We need to go much more deeper if we want to understand the pain and to understand the pain management in this population. Pain. All the research in athletes coming from pain researches in the normal patients populations. So we have not a lot to say about the prevalence of chronic pain in athletes, about the prevalence of acute actually pain, because we have thinking or thoughts that pain and injury, it's the same. But everything is fine with the pain management. You can give only one tablet non-steroids for like to take care of the pain, and in normal condition it can be enough. All the trials in athletes, it's on the non-steroid pain medication. What kind of tablet should I give to those patients, to those sports? But in other hand, when we have problems with those, I can't tell they are not patients, but when we have problems in athletes and we can't manage the pain or the injury, the athletes becoming more and more injured. So then we have a really huge problem with that population. From 2017, the trials coming up, and this beautiful trial that was set in Lithuania, First time I saw and read it in atlas that we can catch about pain, and that we're talking about pain, that the atlas can have pain, and it can actually have some how to say bad influence in the performance even. So other huge problem that we need to talk about, that non-steroids, it's not a vitamins. And very bad thing when you're using them just to prevent the pain. Many trials now are coming up showing that if you're using a non-steroids for prevention, you're injuring your athletes. You're just giving your athletes can become with more risky cardiovascular events. Your athletes can have a kidney injury. Your athlete can have some disbalance of electrolytes. And it's not good to give a pain medication to prevent the pain during some performance. So other thing, the medication overuse. Again, the trials are coming, for example, from 2016, when we had Olympic Games in Rio, when there was made survey actually that came from YASP, World Pain Organization, and most of the physicians who were taking care of the teams were asked, what kind of medication do you prescribe for your patients, and how often, and what kind of dosages? So we can see from this survey that there is half of the part the physician will be prescribed like to prevent the pain. And even we can see like 15 or 30% of physicians will use overdosage for those patients. So again, we have some problems in this situation. Other thing, that when I'm giving some pain relief for athletes, nobody asks them, do you have a chronic pain? And since when you have this pain that you came with this today? Everyone will put a label that it's from your back. It's maybe from other side of injury, but nobody will ask how many time you are spent in pain and where is exactly your pain. So other big issue, that anti-doping issue actually, that we need to be careful what kind of medication we're prescribing for patients. And special consideration should be adverse for Paralympic athletes. They are in pain, especially when they have spinal cord injuries. They can have neuropathic pain. So it's not simple a pain and the symptom. It's much deeper, and we need to, first of all, if you want to treat properly the pain, we need to understand the cause and the mechanisms. So we will go with, of course, all the information that I will present here, maybe according to type of injury. You know that it can be acute traumatic injury, overuse injuries, when the athletes had repetitive injury, not heal, but he just do his exercise or his performance on that not healed conditions. And athletes can have degenerative conditions. It can go together, and it can be differently. There will be no injury, but he can have a degenerative conditions, for example, facet joints and other joints. And those conditions can lead to chronic pain conditions. So again, as I told in my first slide, the injury is not the same as a pain. We can't just go with that. We need to understand types of pain that they can be nociceptive, and in most cases, in normal cases, if we have an injury, actually, in 70% of cases, it will be nociceptive. We have injured or some tissue or damage, there is inflammation, and we will give, how we understand, anti-inflammation drugs for those patients and painkillers. But there can be a neuropathic pain, and this is a factor which leads to chronification. If we do not understand how to recognize this component, we will be again in the trouble. We will be just shooting around, but not taking proper care of our athletes. The pain can be nociplastic. It's a new term that coming from International Pain Society, IASP. As I told before, that athletes can have degenerative conditions. So, and pain can be mixed. It's more complicated than we thought before. So our patients or our athletes can have a peripheral sensitization, central sensitization that can lead into neuroplasticity in our central nerve system. And when someone telling that, oh, your pain is in your head, it's quite correct, because a lot of process coming and going around in our brains. So we need to understand the pathophysiology of the pain. It's not only a one pathway going up and we just have a perception of pain. It's much wider and much complex network. So if we have a nice mood or someone told us a joke, we will smile, and our muscles are moving during this smiley moment. The same is here. Pain network, pain connection, pain pathways going through limbic system. So we need to understand that it's not one way, like we have ascending system and that's it. We have a descending system. Descending system is involved in our pain facilitation and our pain inhibition. So again, we need to know our athletes in what condition the endogenous system is, and we can measure that. But we need to understand that the system is there. We can take picture of acute pain. We can do functional MRI and see the acute pain. And most of the trials that coming at the moment with athletes showing that yes, athlete's brain is less pain sensitive, and yes, exercise and good exercise, especially running, not walking, they just waking up our endogenous system, and it's like inhibits the pain sensation. So from here, we know that to do exercise is equal to be healthy. But if we will go closer, because a picture or selfie not showing what's happening in real life. So the same is here. We need to know the pathophysiology and what's happening in endogenous system. So the trial showed when we have done pain modulation or conditional pain modulation research of endogenous system, athletes not doing so well in this part. They have lower activation of endogenous system if they are repeating their physical activity that can injure. And the chronic overstressing of endogenous system, it's leading to this inhibition of pathways, of pain pathways. So it's dysregulating. That means that our athletes can have, they can be more sensitive to pain, and they will have no, resources to fight actually with the pain. So again, we need to take in mind when we dealing with our athletes. Catastrophizing, it's forgotten thing, but sketch yourself when you are thinking about very painful condition that you experienced before. You can even feel that. So the same here, and all these trials coming from, actually, as I told before, from pain trials and the research and surveys. So the same is with our athletes. They are scared to talk about chronic condition because that coach or other person can take you from your championship or whatever you need to do in that moment. So you will be quiet about that. And you can have fear, and that fear can just conduct other processes in your central nerve system. And what's the main thing, that a catastrophizing condition can alter cytokines responsive to pain. So we have repeatedly the same inflammation just keeping up in that on the injury. And as I told, the trials with athletes, they are coming. And in good way, actually. So there was set it in 2018 one trial to see the pain catastrophizing, have athletes the bigger pain if they have catastrophizing issues. So yes, they have. And what was beautiful here, that was separated the injury and the pain. The physicians or researchers now dividing the injury from pain. They seeing into the pain from the different point of view. Again, we can picture and take picture of chronic pain. We can do again a functional MRI, but we will never understand a mechanism if we will not go deeper. So if we have, for example, the athletes who has a peripheral mechanism or injury, and we were, let's say we were not so good to manage that not injury. We manage injury perfectly well, but we not managed the pain perfectly. We forgot about some components as neuropathic pain, and we have some, we forgot that there can be referred pain. We haven't well examined our athlete, and we have some peripheral mechanisms. We have peripheral sensitization, or which can lead to central sensitization. And then, I know that the words are maybe difficult. Central sensitization can lead to neuroplasticity in your brain, and then we have a chronic pain. And it's not only as just I feel, it's a real condition, that debilitating state can lead to many other causes for those athletes. One of the risks for overuse and opioids and other medications, actually, for seeking, when they are seeking help. So core principles of making the right diagnosis and give a good management for those patients, so or athletes, if they are not patient yet, we need to understand and to examine those patients very well. It's not like I have done scan of lower back and MRI showed a herniation and that's it, that's my problem. No, we need to understand the mechanism of pain, then we can help those athletes. Again, training history, equipment, techniques, psychological factors, it's very important. Nutrition, sleep. Pain should be quantified, and it's very important. Localized, because it can be referred pain, spreaded pain. Sometimes a person can't tell exactly where the pain is. He will say, oh, I have pain in my leg, and that's it. So it's your job to find out what kind of pain the athletes have. Aggravating factors, and of course address kinematics and biomechanical factors. So you are better in that last one. So we will go to managing the pain. When I saw this trial more carefully from Rio in 2016, um, there was no much detail, but for me as a pain physician, I wanted to cry actually. What kind of medication or methods were using the physician during the Olympics for athletes? So we can see that if we have a mild pain, you will, of course, you will go with some non-steroids or you will go with paracetamol. But if you have a severe pain, straight away the discontinuation of anti-inflammatory medication going down, and then some injection forms coming up with opioids. It will be okay if in this trial will be some division that one patient they came back after injury to the performance and others no, and how what kind of medication the physician used. So it would be much nicer to see that. Now from those tables or those results you can do your explanation whatever you like. But if we will see the medication which physician prescribed during the 12 months, so we can see there is not only non-steroids, there is gabapentinoids, there is tramadol, there is other opioids. So why is that? So something that means there's something with those patients where was more than only the pain. So core principle, you can find how to manage with medication. Core principle is from Olympian Committee. And they're telling that you need to combine medication with other physiological or pharmacological measures. Start with lower effective dose. But when you are performing, you can't say which dose is lowest effective or not, because you don't have time for this. Pharmacological and pharmacodynamic principles, we need to know about them. Not always we are familiar with them, according to the slides that I showed before. And of course, we can't give a medication for prevention, because we're injuring our athletes. And again, other issue, it's a substance, prohibited substance that we can't use when the athletes are performing. So main thing is we need to ask ourselves when we're managing the pain of athletes, will this athlete return to playing, and what I can give him? And of course, severity of pain. It's severe, mild, or moderate. And will that athlete not return to play? So there is some medication that we can use, and it's fine in more than 60% of athletes. It will work very well, and it's there is trial on non-steroids, but. Again, if there is recommendation to use less effective and dose for those patients. So again, coming trials from our pain population, our patients. So you can see in this slide, not very well, but I will tell you that if we will use ibuprofen, for example, 603 times a day, and if we will use ibuprofen 200 mixed with paracetamol 500 3 times a day, you will have a bigger effect than ibuprofen alone. So the pharmacokinetic and pharmacological issues, they are very important. Again, if we have an injury in knee or other joint, the COX-2 inhibitors are safer for our patients, and the inflammation they will take off much more than, for example, ibuprofen, which is very good, where we have a straightening of muscles and tendons and nerves. So we need to understand what we need to give for our patient and mix that with physio. because in the end of the slides we will see that we need to be in the team. There is no one pill, there is no one needle for pain management. There is going everything together. So as I told, that's good that everything going right in the right direction. We can give one pill, another pill, or non-steroids injections, and the healing will occur and everything is fine. But what to do with those patients who is something wrong? They are not healing in the proper way that we expected. Maybe I will repeat myself, but again, initial diagnosis, it is correct or not? What we are thinking about those patients, and risk factors, as I was speaking before. So there is other medication that we can use if we have nociplastic pain, and if we have a neuropathic pain component, there is other medication. And again, all medications evidenced for pain population, but not for athletes. But again, the athletes are the same people as our pain patients, with all the risk factors, as I tried to show before with my trial that I'm doing with in cardiology. So we can use those, but athletes can go to play the same day, because there is some medication can have adverse effects, and the dosages can be very high, and the athletes can have dizziness. But if we have a mechanism with neuropathic pain, if we have a mechanism that it's nociplastic, so please, for 1 week, or it depends actually on the condition, I can't tell like for 1 week, it depends on the cause, we need to give regularly some medication to deal with the pain and to deal with the condition that athletes are in. And other sleep and nutrition, electrolytes, calcium, potassium, all they are very important in pain management. Vitamin D, it's very important. Psychosocial intervention that we're forgetting, but you will see if you will just go deeper into pain research that the psychosocial intervention is the main cause and main horse that running around all the trials at the moment. The same is will come into athletes too. And of course, surgery. If you will find the anesthesiologist who will say, "Oh, please, I will just come to me, I will do some injection and you will be fine." Yes, we can do that. We can do it for steroid injections. We can do them whatever the inflammation is. But do we need them? That's the question. First of all, if we have a right diagnosis, again, I will repeat myself, and we tried other treatments and it doesn't work, then yes, please come and we will do that. We will take the inflammation away, but in the same time the rehab plan should be put on. And we never can do injections immediately before the sport preparation or after the injury. We should never inject directly ligaments, tendons and fascias. The same I can tell with joints, because the steroids doing some not good things. So, well, we can do this, but it's not the holy grail. It's one of the part, that pain management part, or cake slide, but not the all cake that we now perform and that's the problem will be solved. Not at all. So, again, networking. It's a wrestler. He was an anesthesiologist, and he was champion not only in the wrestling, but he was champion in pain management settings. So he first called all the professionals in medicine and set up a multidisciplinary pain management for chronic pain patients. So the same I can say today for pain management in athletes. First of all, should be right diagnosis. Second of all, we need to know what kind of physiology or pathophysiology that athlete is particularly showing us, and what kind of pharmacological substance or methods we will give for this particular athlete. It's not there is some, guideline or protocol that I will do this, another one. No, we in all situation we need to use our hands and our brains and our knowledge that we get in a medical school. So I will end with this slide. So maybe I will repeat again myself, but I can't give you some magical tablet or some protocol, because you all have this. Sometimes physios, they are very smart guys and girls. They can show you where the problem is. To say to the doctor, no, I had one patient, she went to all the pain doctors in Northern Ireland in UK, she's Irish girl, and only physio showed that I think there is some problem with your suprascapular nerve. So actually everyone who are participating here, you are the brains and you have the arms that can help, but all together, like team, like if we will take physician, if we will take physio, if we will take a coach or an athletes, for sure they should be involved in all the pain management process. Then we will do better for our athletes. In other words, for our patients. So thank you very much.
Okay, thank you for the nice presentation. Now the questions from the audience. Okay, we have one.
Tai va, prašau, atlikite šitos bandymus, nes jų tikrai trūksta. Tyrimų su endogeninė sistema, sportininkų ir kiek jie gali negražus gal žodis sakyti pavežti, bet trūksta šitų tyrimų pasakyti tiksliai. Kaip matėme, tie tyrimai yra tikrai, jų datos yra 19-18 metai, tai reiškia tik tai mintis apie tai, kad yra truputį kitaip, negu mes visą laiką galvojome. Yra šios dienos. Jeigu mes imsime apie skausmo būtent tos patofiziologinius. Jeigu mes imsime fiziologinius, tai jau buvo senai žinoma. Ir netgi visa ta medicina, kuri ateina iš netgi skausmo medicina, jinai pirmą visą laiką pasakys, kad eik pas kineziterapeutą arba pas kitą specialistą ir mankštinkis, nes tai tikrai aktyvuos tavo endogeninę sistemą. Bet tyrimai, ta riba, kiek, tai tikrai nuoširdžiai kviečiu atlikti tuos tyrimus, nes tiek galima atlikti funkcinį magnetinį rezonansą, naudoti tyrimams, tiek galima įsigyti aparatūrą, kuri tikrai ištiria endogeninę sistemą. Gal nebus tikslumo, kaip ištirti atskirai tą sustiprintoją ir inhibuojančią atskirai, kuri yra pažeista, bet ištirti abudu, kad yra kažkokia disfunkcija toje sistemoje, tikrai šiandieną galima. Ir kas svarbiausia, kad tą galima netgi padaryti be jokių aparatūrų, tą galima padaryti rankomis, tiesiog reikia ištirti pacientą iš skausmo pusės. Ir pamatyti, ar yra centrinė sensitizacija, ar jos nėra. Ir tada galima netgi skirti gydymą ir vėl žiūrėti, ar neišnyko, ar neišnyko. Tai tų metodų tikrai yra, bet tyrimų trūksta. Mes tik žinom visišką basicą.
Okay, one more question.
You mentioned about the suprascapular nerve.
Yes.
Do you have experience treating the pain in our heads with suprascapular nerve?
Yes, I have. And actually I have a lot of patients that coming from a neurology department, and always the request is please do, for example, C3, C4 root nerve block. And I'm never doing this. First of all, I'm just seeing what the patient's body and he's telling me. And then I'm performing the diagnostic because there is a simple test. You can physically see the suprascapular nerve involvement in the pain, but you will never see the dermatomes of this nerve because it's a motoric nerve. And he will never show you some beautiful dermatomes or other spreading. When I'm how to say clear that I'm dealing with suprascapular nerve, I'm just performing that diagnostic block. And if patients are relieved more than 60% with lidocaine or bupivacaine injection, I'm doing some steroid injection. And if it's working, then okay, we're leaving like this. The patient goes to physio just to come back to his normal work because I'm not working at all with arm or shoulder or neck. There is really stiffness and problems. But if I'm lacking with steroids, but I know that's nerve involved, we can perform some pulsed radio frequency. We can neuromodulate the nerve actually. So we do some cryotherapy. So it's possible in our clinic.
It's not a secret. Do you do block from the front or
from the back? We're doing from the back because what I noticed that main cause is the muscles around the nerve and entrapment of the nerve. It's never will come from the how to say, because the nerve is coming from 3-4 part from the neck, and then he's just going into the plexus. But it's always about the nerve in the back and its entrapment. So I never performing. I know how to do it from the front, but I never do, and it's working for patients in chronic pain conditions.
Have you ever saw the patients after suprascapular ligament release?
Yes, I have. Again, those patients have more complex, not only nerve involved. We've forgotten that, I'm sorry, I know that you are a surgeon, but most orthopedics, they will say, oh, with my prosthetic or what other thing, it's everything fine, the bones are in place. But the most pain is coming from the inflammations, from the tendons, from the bursitis, from the other things that just keeping going around and involving the nerves. So sometimes it's very hard to find the beginning or the source of the pain. So again, we need sometimes to do other to give other medication to relieve that central sensitization and to see where is the pain source. And then, of course, we can do some injections in those particular places. But as I told before, never in the tendon, never in the fascia, never in the around. Yes, we can do, but.
Thank you. Do we have another questions? I just want to ask, maybe you have, or you know, the trick or the method which can be objectively measure the pain in the athletes?
No, objectively not.
Okay, let's say objectively no, but maybe one of the methods can give us the true information about, because we know the athletes, they are afraid of telling the pain, they
Yes,
are
that's
hiding
true.
it, they are trying to cheat every time.
Yes, that's the main problem, ethical problem, and as I told, the catastrophization and fears problem. Well, what I can say, you need to take everything together. So, yes, first of all, when the athlete's telling you the pain intensity, like, no, it's 4 from 10, then you need to measure other parameters as cardiac heart rate, blood pressure, and respiratory rate during the movement in that particular painful area. So you will have that objective thing. But again, it should be very careful. You should do this very carefully because you can injure the athletes more. So it should be with cautious. Other thing, what can help you to know your athlete before the championship or whatever he will
Pain
perform.
threshold or something.
Yes, to know of this patient athlete's pain threshold. So it will be much easier. But again, if you want to have objective pain threshold, you need to have you need to know endogenous system it's working or not. So again, you need other measurements in this situation as conditional pain modulation. You can measure with that. There is many trials coming with a pressure threshold that you can measure this in your patient. It's question what you have in your facility to see a pain threshold, to talk with the athlete. You need to have a psychologist. What I noticed from that, maybe I born in Soviet Union, but I just skipped that we all thinking that if I need psychologist or psychiatrist, that means with my head something wrong. So actually no, because the psychologist can do a lot of in these settings. Just to take one example, we had one patient that she had lower back pain and for 5 years, but she was doing very well. She had an exacerbation with that lower back pain. And when her mother had a stroke and she needed to care on with her mother, her pain went it was on the top. And she wasn't telling us what's wrong with her. We knew that the patient has some pain, but it's extraordinary, something wrong with that. And one day when she just opened up and spoke about that, it's in her house and what's happening, straight away the pain went down 50%. So she felt some relief. So it's all mechanisms and networks in our central nerve system. And as I told in mechanism, it's everything involved because all the pathways goes to our limbic system and it's involved in our descending system as well. So, it's everything connected.
Thank you very much for presentation. Thank you.
Thank you.